Hello to everyone tuning in from around the world, wherever you are. My name's Eric Grant and I'm the Communications and Media Manager at UICC. Welcome back to the World Cancer Day live broadcast program. I'm joined now by Dr. Muhammed Aasim Yusuf, CEO of the Shaukat Khanum Memorial Cancer Hospital and Research Center in Pakistan. Dr. Yusuf, how are you doing today on World Cancer Day?
Fine, thank you. How are you, Eric?
I'm great. Thank you so much for joining us today. My first question, obviously, concerning equity, which is our campaign theme. I know that your hospital is doing amazing work in reaching out to underserved populations. Perhaps you can give us a brief overview of the hospital's work, how it got started, its mission, and how you see its future.
Yes, thank you. Well, thanks for having us on this program today. Very important day, World Cancer Day. So the Shaukat Khanum Cancer Hospital, Memorial Cancer Hospital and Research Center in Lahore was founded in 1994. But the story really dates back to the mid-1980s. There was a very famous cricket player in Pakistan, now known internationally, called Imran Khan. He was the captain of our national cricket team. His mother developed advanced colorectal cancer in the mid-80s. And it was his struggles in trying to get his mother treated within Pakistan. He eventually had to take her overseas, which was one of the main driving forces behind his desire to establish this hospital. The other being the hundreds or perhaps thousands of poor suffering cancer patients that he saw as he progressed with his mother through her cancer journey in Pakistan, who did not have the advantages that he had, who could not take their loved ones overseas for treatment. And he realized that there was a great shortage of good cancer treatment facilities in Pakistan. So these two things together led him to start a national and then worldwide campaign to raise funds for a tertiary care cancer hospital to be built in Lahore in Pakistan, with a mission to provide world-class cancer care, both palliative as well as curative, to cancer patients in Pakistan without distinguishing between those who could pay for their care and those who could not. And that is the model that we've followed ever since this hospital opened in Lahore in 1994. That once patients are accepted into the system for treatment, physicians and nurses are blinded to the patient's financial status, and patients get whatever treatment they need, regardless of whether they're paying for their care for themselves or someone else has paid for them. Because of the huge number of cancer patients that we have in Pakistan, and because up to 30% of our patients in Lahore came from the northern parts of Pakistan, the Khyber Pakhtunkhwa province, and 5% of our patients actually came from Afghanistan, we established a second hospital in the northwest of the country in Peshawar in 2015. And again, because of the increasing burden of cancer and the paucity of facilities, we're now building our third and Pakistan's biggest tertiary care cancer hospital in the south of the country in Karachi, which is our largest city.
Yeah, thank you so much. And yes, indeed, the issue of displaced persons in cancer care is something we've looked at UICC, and they face certain challenges in addition to access to resources, emotional trauma, physical trauma. And I know that your hospital welcomes people from outside Pakistan, from Afghanistan, Tajikistan. Perhaps you can explain some of the challenges you face in providing care to displaced persons.
Yeah, so even within patients from within Pakistan come to us from, sometimes thousands of miles away. But of course, patients who are not from within Pakistan face additional challenges in terms of actually travel to the hospital, in terms of getting to the hospitals in Lahore and in Peshawar, and then in staying in that city for the duration of their treatment. As you know, cancer treatment is prolonged, multi-stage, involves coming and going to hospitals for chemotherapy, radiation treatments, for surgery. And so what we've done is, first of all, we've increased the number of hospitals that we have. And secondly, we provide facilities for accommodation for patients and their relatives when they come to the hospital. So when they don't need admission, we have what we call musafir khanas, or hostels nearby, which are run by other charities for our institution, where patients and their relatives can stay often for months at a time during the course of their treatment. In these facilities, we provide free meals and lodging facilities. And obviously within the hospital itself, all care is provided completely free to those who cannot pay. This includes meals for the patients, for example, but also a relatively new initiative is that we also now provide meals for the parents of accompanying children with cancer. 11% of our patients are children with cancer. And we also provide accommodation and food facilities for the parents of such patients. So the refugee population in particular is often a population that has had limited access to care in their own countries. And so they'll often present at a late stage when curative treatment is not possible. But we are fortunate to have one of only two palliative care units in the country, and the only one recognized for postgraduate training in palliative medicine. So we are also able to provide palliative treatment when active treatment is no longer possible. So we do try and provide the full spectrum of disease from diagnosis through treatment to palliation and symptomatic and supportive care.
Oh, yeah, thank you so much. You raised two great points, and I think it's really interesting, the geographical location and the what that entails in terms of transportation, accommodation, and that kind of support is as important sometimes as treatment, because otherwise patients drop off, don't pursue treatment. So those are excellent initiatives. Thank you so much. The other one you raised is about the late stage diagnosis. Obviously, the earlier we catch a cancer, the easier it is to treat successfully. And for many cancers now where we can screen, the survival rates are quite high, but that does require the resources. What kind of technology and innovations in cancer care are you able to provide to your patients in Pakistan?
Yeah, another great question. So, it's part of our mission statement that we aim to provide world-class treatment. We do that obviously because that's a right of patients, that they should get the best possible treatment that they can, but also because we aim to act as a model institution. We understand that one institution or two or even three cancer hospitals now cannot cure the close to 200,000 new cancer patients that are seen in Pakistan each year. But what we do want to do is to try and combat the nihilism, if you like, that has existed, that, excellence is a Western or an alien concept, something that can only be achieved in the West. We aim to show that it is possible to achieve excellence in Pakistan, and that there are alternative models of funding. We don't need to wait for the governments necessarily to provide all medical care. So as part of that promise of providing world-class treatment, we aim to stay at the cutting edge of technology as far as possible. We invest heavily in diagnostic equipment, for instance, the usual CT scanners and MRIs and so on. But we were also the first institution in the country to install a PET-CT and a cyclotron system back in 2009. We now have three such scanners, two in Lahore and one in Peshawar. Similarly, in terms of treatment, we have the latest in radiation treatment equipment. We have the largest radiation capacity in the country, 5 linear accelerators in Lahore, 2 in Peshawar, and 10 planned for the new hospital in Karachi. And these are really cutting-edge, state-of-the-art equipment with stereotactic radiation capability on treatment imaging and so on. And again, it's not just so that we can provide optimal treatment. That's the main thing. But we also recruit our consultant staff from the Pakistani diaspora overseas. These are highly trained individuals who then need to be provided the equipment and the tools with which they can practice the skills that they've acquired and can provide optimal treatment for all our patients. Turning to chemotherapy, we try as far as possible to provide the latest in treatment in terms of chemotherapy drugs, targeted therapy, and so on. But we do always wait for the data to firm up. We don't necessarily go out and start using the latest drug that's been shown to be effective at ASCO or a similar meeting. We do wait for the dust to settle, for the data to firm up and show that those benefits are sustained. And then we try and invest in providing that kind of treatment too.
Oh, this is certainly very inspiring. You did mention what can be done without necessarily waiting for government action. However, what would you see, what would you like to see perhaps in terms of national cancer control policies developed that could close the care gap in Pakistan?
Yeah, so the commonest cancer that we see in Pakistan is breast cancer in females. As you know, that's an entirely curable disease if it's picked up early. And unfortunately, although our stage-by-stage survival at our hospitals is similar to that in the West, the preponderance of patients that we see tend to come at an advanced stage when cure is often impossible. So at a national level, obviously, we need to create more awareness of conditions like breast cancer, which if picked up early can be entirely cured. We need to try and eliminate the stigma associated with some of these diseases and the inherent cultural issues which often prevent young females from seeking help at an early stage. We need to increase the number of facilities where such conditions can be diagnosed and treated, obviously. But there are other conditions too in Pakistan that can be eliminated or certainly greatly reduced by public health efforts and so on. So one of the commonest cancers we see is primary liver cancer or hepatocellular cancer, which in Pakistan is largely due to hepatitis B and hepatitis C. Vaccine for hepatitis B exists, and if we can increase uptake of that vaccine, that would certainly help to reduce the burden of hep B associated HCC. And of course, hepatitis C is now completely curable. So if we could increase access to curative treatments for hepatitis C, that would help reduce that quite significantly. Lastly, and perhaps most importantly, from a public health point of view, tobacco and other ingested substances that are used in our country. So tobacco in all its forms, and also the use of betel nut, which lead to lung cancer, cancers of the oral cavity, and so on. These are entirely preventable, and if we had more legislation, perhaps more taxation on these products, that would help to reduce the incidence of these tumors too. So I think from a national public health point of view, obviously in investing in cancer infrastructure, in technology, and in facilities, in providing funding for treatment is obviously important, but these are other things that we can also do to try and reduce the cancer burden over the next 2 or 3 decades.
Yeah, that's very true. I mean, they say up to half of all cancers are preventable through lifestyle changes, healthier lifestyle, tobacco control, and physical activity, and then of course detecting screening for cancers early. In terms of innovation and prevention, what sometimes there is a cost access issue, but what kind of innovations are you seeing that could be very helpful in limited resource settings, perhaps mobile screening units or other diagnostics tools that could really help transform the way cancer may be prevented and addressed in lower resource settings?
Yeah, so I think screening is obviously the elephant in the room. There are well-established screening programs and plenty of evidence, for example, for colorectal cancer screening and so forth. But unfortunately, we don't have any national programs for either breast cancer screening or for colon cancer screening or any other cancers, in fact. And that's really a problem at the national level. I mean, that's not something that increasing the number of cancer hospitals per se will necessarily deal with or will tackle. The way we see the future for our own institution and the way we are developing our cancer treatment network is that we aim to establish a series of hub and spoke hospitals. So our hospitals in Lahore, Peshawar, Karachi in the future, and perhaps Quetta in Balochistan will act as our main tertiary care cancer centers. And then we hope to establish a number of smaller diagnostic and treatment facilities in a kind of hub and spoke model around each of these centers, where the diagnostic facilities will be available and what we call euphemistically the simpler treatments, day case chemotherapy, perhaps day case surgery, the simpler radiation treatments will be carried out in those centers, because it's very important that we devolve care closer to where people live, because travel and accommodation and so forth are huge issues in Pakistan for patients. So we do hope that, in the next 20, 30 years, this is a model that will be fully established. And we look forward to a day when all the cancer patients in Pakistan can be treated at one of our facilities across the country. We are already represented in over 65 cities and towns across the country in terms of laboratory collection centers and so forth. So this is the natural way that we see this mission progressing.
Well, thank you so much for sharing that with us and giving your time today. Perhaps just to end up, if Close the Care Gap is the World Cancer Day campaign theme, could you perhaps tell us what Close the Gap means for you?
Yeah. So closing the gap really is all about recognizing the inequities in cancer care around the world. We understand that these are geographical barriers, which we've talked about, the technology barrier, that equipment that you need to diagnose and to treat cancer can often be very expensive. Funding and the resources needed to actually run these hospitals, chemotherapy, drugs are also very important. But we've tended to use generic drugs where we can get chemical and other equivalencies done. So, there are ways around these things. If we try and help ourselves, there is plenty we can do. There are barriers around language and paucity of cancer treatment facilities, but we're a proud member of the UICC, and we understand that it will take a united global effort to build alliances that are necessary to eliminate the scourge of cancer over the next 2 or 3 decades. And as we say in our part of the world, inshallah, with the will of God, that can be done.
Well, thank you so much, and we have a great rest of the day for World Cancer Day. Thank you very much, Dr. Yusuf.